Cancer has long been thought of as a death sentence.
Delay kills. Even the best, most expensive MRI machine now can only detect a tumour when it's 0.5 centimetre in diameter. There's over 1 billion cancer cells. The target in the NHS from diagnosis to treatment is 62 days. You wait 2 months, some of those cells have spread outside to lymph nodes, the liver, to lungs. 7.4 million people are waiting for something in the NHS. The NHS needs to do something different.
Why haven't we yet seen AI really help cancer scientists?
For cancer, there's so many variables to analyse that we can't see the pattern. It's a puzzle, and nobody knows the answer. Only AI can solve the riddle, combining the intuition of clinicians with the evidence base of AI.
Are we boxing in the bright minds of oncology?
That's an interesting concept. The future is going to be about...
Today, I'm joined by Professor Karol Sikora, an oncologist of 50 years who's recognised as a world-leading authority in cancer care. We're going to consider the entirety of oncology, why more and more young people are getting cancer, why it's so incredibly difficult to treat, and if AI is really going to be the saving grace that it promises to be. Professor Karol Sikora, you have been an oncologist, and a world-leading one at that, for quite a long amount of time. Perhaps 50 years, I think that's
exactly
correct.
50 years.
Fantastic. So how has the field of cancer care changed in your time?
You know, Abigail, it's changed totally. When I look back how we began, it was like being an amateur. What everybody was doing was very amateurish. Now, it's much more professional. For the patient, that means it's a much smoother journey. Not always, but most cases, it's very smooth from the moment of diagnosis to getting the various investigations to plan treatment, the planning of the treatment, whether it's surgery, radiotherapy or chemotherapy, and then the execution of that care. We spend a lot more time focusing on giving the patient a good time during the journey. In the past, it was awful. The drugs we used made people sick. We didn't have drugs that could suppress the nausea, so they just continually vomited. They got psychogenic vomiting, which meant if they met me in a supermarket, they'd start vomiting if they just saw me. The radiotherapy, people waited all day to get a 10-minute treatment, and that's sort of gone, and there are problems still, but the whole journey is much, much smoother than it was 50 years ago.
If you had to pick a single development, perhaps a drug that's come into the landscape that's been the most revolutionary, what would you say it's
There's
been?
no single drug, but there is the personalisation of care, which is totally different now. By that I mean that if you have 2 women with breast cancer, Mrs. Jones and Mrs. Smith, they may have exactly the same pathology, exactly the same staging and grading. Everything looks completely similar. And yet we may give them very different treatments because we can now predict that their responses are going to be different to the treatment that we have offering in the basket of treatment that we can give. And that, to me, is something you don't see happening. It doesn't happen in 1990 or something, suddenly it changed. It's gradually crept on us. And that's where I see artificial intelligence coming in. It will push much more precision in determining which treatment to give to which patient. And it will result in better outcomes by doing that.
Yeah, and we'll touch on personalisation a little bit more later. Cancer has long been thought of as a death sentence, even I think in the 2000s and the 2010s. Is that still the case?
It's got much better. So when I started 50 years ago, 30%, 33%, exactly a third of patients were cured of their cancer. Now it's over 50%, just over 50, about 51%. Obviously it depends on the type of cancer and how much it's spread before it's diagnosed. But overall, people are living longer. Of course, cancer is a disease of predominantly older people, so they have a defined lifespan, which may not be more than 20 or 30 years. And so we're gradually coming to the conclusion that if you could just manage that cancer to stay quiet for 20 or 30 years, you would save a lot more people because they would die of something else before the cancer would get them, basically. So that's the sort of current thrust, how we can control the disease with more gentler care rather than going for a big bang, which has a mortality on its own with a treatment and so on. Not always the case. Sometimes we do use fairly aggressive treatments such as bone marrow transplantation, CAR T-cell therapy, and various other immune blasts at the body. But the idea is very much to control cancer for a long period of time so the patient can have their normal life expectancy.
And let's touch a little bit on the prevalence of cancer because it has been increasing. I've got some statistics here. Cancer prevalence has crept up by 13% since the 1990s. And obviously, I think there are multiple factors compounding the issue. For example, aging populations and obviously an exponentially growing population plus advanced screening. Are there any other aspects that are driving the increase in prevalence, do you think, or is it mostly those things?
There are. The biggest dominant factor is the age of the population. So this country is mature, like most of Europe. So 26% of people in Britain are over 65. That's the target age for cancer, people in their 60s and 70s. Of course, children get it, and of course, young people get it, but it's much smaller in terms of incidence. Other parts of the world, the age distribution is totally different. In the Gulf, the Arabian Gulf, for example, Abu Dhabi, Dubai, less than 3% are over 65. So the incidence of cancer is much lower, but that's going to change because people are going to get older. The same in the poor countries of the world, the poorest being in sub-Saharan Africa, where, again, the age distribution is very skewed and the average life expectancy in the past has been less than 60. That's changing, and that's a good thing. It's changing because of better healthcare, better malaria, tuberculosis, HIV control, and that means people are going into the cancer age group. But there is one other thing, and it's a puzzle, and nobody knows the answer, and that's under 50-year-olds. If you look at the data of under 50-year-olds getting cancer, for certain cancers, certain common cancers, colon, lung, breast, lymphoma, melanoma, it's risen dramatically, doubled or even tripled in the case of non-Hodgkin's lymphoma, for example. And we have no idea why. Now, before you jump on it and say, oh, it's COVID and it's vaccines and it's mRNA and all these guys with yellow placards on the streets out there, it's not that, because it started going up way before COVID hit and way before there was any mRNA vaccines. So what is it? And so the most likely thing, as far as I can see, is a lifestyle change, that people have changed their lifestyle. But that in itself, and they change their body weight, they change the way they do exercise, they change what they eat, the obesity rate's different, how they do exercise is different. I mean, people in the past more people had jobs that required physical input into their job from themselves. That's more or less gone now. So there are lumberjacks and there are builders that have to go up scaffolding and take bricks up and so on. But they're very few, and they've changed over the last 20 to 30 years, which means the one thing it could be, and we all think the same in the scientific world of cancer, is the microbiome, which are the bugs that are in our gut, have changed somehow because of all these things. And because there's so many variables in what constitutes the microbiome, some positive, some negative in terms of cancer incidence, it's only AI that can solve the riddle. There's so many variables to analyze that we can't see the pattern. And I think over the next decade, we will see the pattern. And of course, there is something you can do about it. You can change the microbiome if you know what you want to change. There are already clinics, private clinics, of course, in Harley Street, that will offer to change your microbiome, but we don't have good data, good scientific evidence base that we really know how to change it to make you much less cancer likely for those diseases. Interesting.
And I think we also see that with cardiovascular disease, because if you take, for example, an indigenous population living in a tribe and they migrate to a city, they start accumulating diseases that we have, cancers, cardiovascular disease, hypertension, that kind of area of disease. So it seems that westernization and urbanization are contributing to an increased cancer
Absolutely.
prevalence. But that to me says that there's something much more intrinsic about future cancer treatment strategies, as in we need to kind of address the societal infrastructure here, stress, perhaps, the way that we're working, the way that we are just now living sedentary lifestyles and having to rely on ultra-processed foods, which are contributing to the disease that we're getting. Do you think that addressing the microbiome is purely the only strategy that makes sense here?
No, I think you're right. There's so many variables interplaying here. I visited a longevity clinic in London last week, and there's plenty of them rising up now. Wellness and longevity, the biggest business in private medicine at the moment. And a lot of it's gobbledygook, a lot of it's got to have no scientific base. But there is something there, a lifestyle alteration to make you live longer. And my advice, from what I've seen, what you need to do is stay slim, stay fit, and look at your diet and what you eat. And ultra-high processed food, you don't want vegetables, nuts, lots of, no need to be vegan or anything or even vegetarian, but just lots of healthy food. And that's all you can probably do. The problem with longevity is because we don't know all the factors involved, it could result in nothing. There's no guarantee. I mean, the average age of death in Britain has gone consistently up over the last 30 years. So, and that's why, we read in the papers, the pension problems is because of this. People are living now to an average of 81, 82, women slightly longer and men slightly less, and it's going to go up a bit more. COVID put a blip in it. It sort of halted the rise for a bit, but it'll come back. And it will probably end, by the end of the next decade, the average age will be 85. And there is no planning for care homes, for all the things that go with old age. Yeah. But of course, I like to think 70 is the new 50. So it sort of is. The people of 70 now aren't behaving like people of 70, 50 years ago when I started. People of 70 in the old days would not even get into an acute hospital. They'd go to some sort of geriatric facility if they were wrong. Yeah. And now, of course, all healthcare systems in the world treat you as an equal, not depending on your age. So cardiac stenting, cancer care, radical surgery, all these things are carried out on people way into their 90s now. So that's changed things.
Yeah, absolutely. Touching a little bit more about the growing prevalence in younger people, I read, so this is one study, so I'm not sure how much we can read into this, but I did read a study where some researchers found that childhood exposure to a specific strain of E. coli was perhaps increasing the risk of colon cancer a bit later in life, but still under the age of 50. So they kind of speculated that perhaps this infection that you have when you're a child is increasing your likelihood of developing colon cancer before you're supposed to get it. They said decades before you're actually supposed to get it. I wonder if you'd read that study, if you had any thoughts on it, and if you could maybe explain how an infection that you get when you're under the age of 10 then increases your likelihood of a cancer developing.
I have seen that study, and it's very interesting. And it's one of several studies like that, where an infection way back, 40 or 50 years before the actual cancerous event happens, seems to predispose to the cancer. The mechanism almost certainly is that the inflammatory change specifically leaves a memory in the cells, the epithelial cells lining the colon, which are subject to all sorts of insults from the food we eat and the bugs that ferment the food in the gut. And that results, for some reason, in their memory of the insult they had, changing the way they respond to it, and that results, for some, in the development of cancer. I mean, cancer is an inevitable event in the human body because there are certain processes that are like cancer, use the same genomic pathway. Wound healing, for you cut your finger, very simple, it heals. That healing process is all the invasion of cells, spread of cells within the wound, and then the closing of the wound and the shutting off it, the new vasculature that occurs in the healed wound. That all is part of exactly the same thing that a cancer cell has to do to develop a tumor, to actually grow. Similarly, the placenta, the fertilized ovum, has to invade the placenta to create the trophoblast, which becomes the placenta. And so that, again, is a cancerous-like process. And these are natural processes, wound healing and ovum implantation. And so all cells have the gene sequences to do that. And when they're subverted, it becomes a cancer. Now, how it gets subverted, in this case by an infection in childhood, leaving a memory there, we just don't know and we don't understand. And again, that's where there are so many variables to look at. I always think when we look at certain things like the biochemistry of cancer cells or even patterns of cancer cell growth, you're just seeing stills. But if you had a still of a ballet, you wouldn't know what ballet it was just by looking at the dancers going around the floor. Right. No sound, just the stills of the ballet. But if you had the motion, you might guess it was Swan Lake or it was Giselle or something like a load of swans and a bad guy. That would be Giselle, you see. And could you do that with cancer cells? The technology is coming to sort of begin to do the flow of molecules. I mean, the biggest problem in biology, as far as I can see, is transcription control. We don't understand gene expression properly even now, even after huge amounts of research. And that's because it's not a linear sequence like DNA. It's a series of timed events that lead to biochemical change downstream. And that's probably what goes on in cancer.
And we touched a little bit on artificial intelligence and how we're expecting AI to really help scientists probe a deeper understanding of the processes involved. But AI has been around since 1950s, since Turing's seminal paper. So why haven't we yet seen AI really help cancer scientists?
I think it's coming. What strikes me that the best way to use it is for things where there's too many variables for us to analyze. So if you've got a hospital, say there are 1,000 beds, and tonight 10 people will die in those beds, but you don't know which patients. Can you, by using AI, go through all the variables that are there, their blood pressure, their temperature, their urine output, all this sort of stuff, all the 50 or 60 blood tests that patients in intensive care units get done every day? Can you look at patterns that the human eye doesn't see? Minor changes, ratios of change. And there are programs that are beginning to do that. You can predict cardiac arrest. And if you can predict cardiac arrest for those patients that are not terminally, irreversibly damaged, you could try and prevent it. So for cancer, it's different. You're trying to look for a whole load of variables that you can't see. The human eye can't cope with all these variables. Even a brilliant Cambridge mathematician couldn't actually see these variables, but the computer can. And once you have that, then you can do personalization that we talked about before, but you can also start seeing biochemical patterns that would lead to cancer and solve the problems. So one of the big problems in cancer, when we screen for cancer, say breast cancer, we pick up a lot of abnormalities. It's called ductal carcinoma in situ that wouldn't necessarily lead to breast cancer, and we don't really know what to do. Is there some way the AI could sort out which are the bad types to have and which are the good types that we could just leave and not do any surgery, just follow the patient up?
That's actually a really interesting point that you've just made. I don't know if you've read The Age of Diagnosis by Suzanne O'Sullivan, but it's a fantastic book. I would really recommend you read it. But she wrote about how kind of against the whole diagnostic craze that we're experiencing now, because obviously prevention is so crucial for cancer. But she mentioned how screening is so important because we flag any potential cancer cases, but we also flag patients who have tumor cells that might not necessarily turn into cancer. So it's trying to balance healthcare system capacity to treat preventative cases with diagnostic rigor. So I think it's a fine balance. I don't know if you had any thoughts about that.
It is. And the best example, Abigail, is prostate cancer in men. Men my age have a high incidence of prostate cancer. If studies, post-mortem studies for people that have met sudden death by being knocked over by a bus or whatever reason, men over 70, nearly 60% have early prostate cancer in the prostate. And that's why prostate screening is not a great idea, because you'll pick up a lot of cancers that won't really develop into much. And again, can we sort out biochemically those patients that have prostate cancer, early prostate cancer, in which it's not going to affect their longevity? Because there's no point, if they've got no symptoms, there's no point treating them. So that's why there's a lot of controversy about doing the prostate-specific antigen, the blood test for prostate cancer.
Right.
It's great as a follow-up marker to know how the treatment's going, but it's not great as a screening marker. And screening processes always worry the worried well. So the worried well are the ones that go forward for screening on the whole, and they become even more worried if they get a test. And none of the tests we have, whether it's mammograms or it's cervical cytology or PSA or even colonoscopy for colon cancer, are 100%. They all have an error. Again, if you go down to longevity clinics, I'll recommend you have a total body MRI. And but 10% of total body MRIs find an abnormality.
Wow.
But most of them are irrelevant. So it's just some little shadow somewhere, but you then have to sort that out. So the cost of the MRI may be £3,000 or £4,000, but the cost of sorting out the abnormality may be tens of thousands of pounds. And the patient, having been worried enough to get the MRI, becomes a nervous wreck at the end of it all, because you've gone through all this investigation. And we can't reassure people that they're not going to get cancer. However, even if the evidence, they haven't got it at the moment, that doesn't mean it's not going to come. And everything has a limit of sensitivity. So even the best, most expensive MRI machine now can only detect a tumour when it's half a centimetre in diameter. And half a centimetre is over 1 billion cells, billion cancer cells. So the cancer's been there some time. Yeah.
And about fear-mongering, like you said, cancer has very, very scary connotations even today. Even though some skin cancers, for example, extremely treatable, you might have a 90% survival rate. Nonetheless, increasing screening capacity does come with a risk that we're fostering an environment where patients feel increasingly scared of the results of said screening process. And while, again, prevention is heavily stressed nowadays as favourable over cure, nonetheless, we're creating the perfect storm for a hypochondriac to thrive in. Do you think?
We are. And the problem with all screening programs is the costs, both financial costs and psychological costs, are not with the initial investigation, whether it's, say, a mammogram for breast cancer. It's with sorting things out afterwards, because much of the time the answer will come back ambiguously. Maybe it is, maybe it isn't. So now what are you going to do? For the patients, the decision maker, they have to sign the consent form for a biopsy or anything. What do they do? And different people have different attitudes. And I'm very poor. And men are different from women, of course. And it's very strange. Men, on the whole, avoid screening calls. Women do. So the colon program, which obviously everybody gets colon cancer about the same rate. Men slightly more actually than women, but not much more, 1.2 times for men. But women do it when they get their poo test through the post from the NHS, and men tend not to do it. And obviously there's ethnic differences, socioeconomic, educational differences, but certain people don't like screening and they won't have anything to do with it, and others love it. They can't get more of it and they pay for it. They go and have well-person clinics like the longevity clinic.
Interesting. So that's that's something that I guess every scientist and every doctor needs to be aware of as we're focusing on AI deployment, is balancing the psychological risk of increased screening. Let's go back to personalization, because this is a big topic in cancer care. I think personalization is very obvious, for example, for breast cancers, where you have three or four main types of breast cancer. You try and stratify the patient into those 4 types depending on the gene expressed, and then give the treatment depending on the gene expressed. So it's supposed to help work out how the patient is going to respond to a particular drug, and therefore increase the likelihood of them surviving the cancer for longer. But nonetheless, when I was doing my sort of lecture series on oncology, discovering that actually a single tumor is a complete mosaic of genetic mutation, and that every single cell might have a completely different mutation to its neighbor, for example. That's a bit hyperbolic, but you can imagine that it's quite a vivid landscape of genetic mutation. And therefore it's really, really hard to create a treatment regime that's going to kill every single cell, because not every single cell is going to respond to the same treatment in the same way. So how exactly can we move forward with personalization? How exactly can we get it to be maybe not 100% effective, but definitely more effective than it is at the moment? Because at the moment, you give someone a personalized cancer treatment regime, and sure, they respond well to it, but obviously not all cancer cells are killed, because they're not all susceptible to the drug, and therefore the cancer grows back. And that's the big problem with cancer, do you think?
Yeah.
Isn't it?
Very good points, Abigail. The multiclonality of cancer, this is the problem. So if cancer arises from one cell, and all the cells it produces in the clone are from the same cell, they're all brothers and sisters, they all look alike, they're identical twins, then you just work out the features of the cell, and then in theory, if the therapy is going to work for one cell, it'll work for all the cells. And that would be a single clone of cancer cells. Now, probably that's how it starts, but as the cancer cells spread, the process of metastasis, change of place, metastasis, means that some of the clones of metastases may have different characteristics to the parent, to the primary tumor. And that's one of the problems, and that's probably why cancer treatment fails in some patients. I think, nevertheless, personalization for early cancers will allow you to eradicate that clone before it starts deviating from itself. So the problem of personalization until now has been there are so many variables, and ultimately next generation sequencing, which is now done to look for mutations in genes you wouldn't expect to be mutated in a certain type of cancer, and may have a low level of mutation, maybe less than 3% of patients have that genetic alteration, but it may lead to the identification of new therapies for that mutation. We call it tissue agnostic therapy, because it's not, agnostic sounds like a religious word, but it's the tissue agnostic means it may be breast cancer, but it may respond to a drug we use for lung cancer. And these therapies are tissue agnostic. They don't care what the cancer is, they look for the mutation. And the way to find that mutation is not by traditional immunohistochemistry, where you pour dyes on the tumor and look for mutated proteins, but you actually do next generation sequencing, and you sequence the total DNA. And it's feasible to do that, but within 48 hours you can have the total DNA sequence. Now, I challenge any doctor to look at however many base pairs you've got in NGS and come up with any meaningful look at it. It's got to be a computer, and the computer can look at spots that are different, look at areas that are methylated, that may be transcribed, and all these sort of things. You can learn an awful lot. And we're in our infancy. And I think the next step after that's sorted out, and we're talking 10 years down the road, is why do you need to get tissue? Tissue is fraught with difficulty. Is it cancer? Is it normal cells? Is it infiltrating lymphocytes with an immune reaction to it? Can you not get that information by looking at circulating DNA in the blood? So circulating tumor DNA at the moment is at an early stage of its evolution in terms of intellectual ability to predict things. But I would say within a decade, you'll get as much information from a small blood sample, maybe even a finger prick, as you will from taking a whole lump out and looking at it in the lab. If you talk to pathologists, they get very defensive because pathologists love looking at shapes and using very long Latin and Greek words to describe what they see. And they talk about baby bottom cells and things like that. And they say, well, come on, what is it? We don't know. That's why we're giving you these words, you see. But the future is going to be about actually just taking a small blood sample and predicting what type of tumour it is and how it's likely to behave. And then on top of that, giving you a printout of what different therapies would do for that tumour. So when you sit in a clinic in the hospital, you've got a computer in front of you. It's got lab data on the patient. It's got liver function tests, blood test results, and so on. Obviously, it's got patient demographic, name, address, and so on. And what it doesn't have is anything that can predict what's going to happen to that patient if you give drug X or drug Y.
Sure.
And that's what the consultant is doing, is using his or her experience to try and make that prediction. And once the computer can do it, then it becomes more precise, I would predict. And different doctors will give different treatments to different patients. So the same patient, they'll give different treatments. Now, we're much more frank about criticizing or constructively criticizing each other now at what we call tumor boards in America, multidisciplinary team meetings here in the UK. And it allows a forum for people to say what they think is best. Most cases are dead straightforward, but there's different ways of doing it. And that's where artificial intelligence will come in, not just a prediction, but actually showing you the optimal clinical care pathway for an individual patient based on all the data you've got in front of you. And there's no reason a computer can't be as good as even the most high-powered multidisciplinary team in London, for example, in terms of discussion. So, and then you can factor in the social situation of the patient and the financial toxicity, whatever you're suggesting. Some of our cancer treatments are over £250,000 a year. I mean, it's unaffordable for any health, nothing to do with the NHS. It's just unaffordable for most healthcare systems.
Right. Multidisciplinary teams might have different opinions on what the best course of action is. Is that the same for all domains of medicine? Is that particularly an issue in oncology, and how much of an issue is it?
Oncology was the first to introduce the concept of multidisciplinary team being sort of compulsory for optimal management. Cardiology, especially ischemic heart disease, coronary artery disease, again, that's been introduced because there are certain difficult decisions in cardiology, such as whether to stent a blocked coronary artery, or whether to do a bypass, an open bypass. And so these things are better done with a group of people looking at the same data, showing the images, and then coming to a conclusion. With cancer, we show the images, we show the pathology, and then we sit and try and work out what's best. And you do get a diversification of opinion, which doesn't matter. And as long as everybody's calm and doesn't start slagging each other off, it does happen now and again. It needs an effective chairman to keep everybody down. Then we can move forward. And I think it's really quite a challenge. And it really started in the States. I mean, when I started oncology, I went to the States as a clinical fellow at Stanford, and they were doing it there. And what it was a shock to hear the consultant whose case it was being seemingly attacked by the residents, the junior doctors were attacking him for saying, why are you doing that? Making him justify what he was doing. And we'd never have done that here. The boss was revered and you'd say, yes sir, no sir, 3 bags full sir. But it didn't work like that in the States. And it's still a little bit like that. There's a difference in European medicine, where, especially German medicine, where you have a doctor, professor at the top, everything has to go through, and it's usually a him, by the way, so and the American culture, where even the most lowly junior, the first month qualified, can question the boss, and it's sort of welcomed, that questioning. And I think it's healthy, and that's where AI is fantastic, because there's no emotion about AI. This is what I think. You take it or leave it. And I think that's partly helpful to the whole medical hierarchical discussion.
And standardization can really only be a good thing. On the contrary, though, I read a Nature article published in 2024 asking doctors to flag cases as potentially high risk of skin cancer versus low risk based on a series of images. And they were asked to do it by themselves, and they were asked to do it with an AI helping to guide their decision. And it was really interesting, actually, because the quote-unquote high-performing clinicians, so the ones that were diagnosing correctly a lot of the time, their accuracy dropped when using the AI. So in the first instance of just them and their brains, they identified 26 cases incorrectly. So incorrectly labeled as either skin cancer, yes, or skin cancer, no. However, with the AI, that then increased to 38 cases that were then wrongly identified. So that's quite an interesting new dimension to the world of oncology, is these excellent clinicians that have a gut feeling about a patient's case and think, I think it's this, or I think that we should do this. With an AI potentially then making an error, are we boxing in the bright minds of oncology?
That's an interesting concept. I think not, because I think the bright guys and girls will actually see they can use AI to help them rather and not fight it, just let it do it and then override it when necessary. And I think that's everyone would like to think the wise old physician, the old general physician that could suddenly say, this patient has tuberculosis from the end of the bed. And he was right. They used to do that when I was a first-year doctor. And you wondered how they got there. And they would never explain to you how they got there. Like a magician, a good magician never explains his tricks. And it's exactly the same way a good diagnostician never explains how he or she is getting there. But I think the future will be for the good guys will definitely enable AI, and it will enhance their diagnostic capacity. And more importantly, their capacity to take all the data and translate it into the optimal treatment pathway. That's what you're really trying to do. All the data's there. Some of it's mathematical already, and you can digitize pathology now quite easily. So it can all go into a digital form, just like the MRI and the CT and the PET CT. All these things are in digital format. So it's all maths. You pile it into a computer, come out with things, and there you go. And in the future, as I said earlier, maybe some circulating DNA in the blood will be factored in there. Yeah. And everything will be put into a box, and out will come a list of treatments with the chances of success 10 years down the road. And at the moment, it's based on clinical experience of the individual and the literature, which is full of clinical trials. But we all know the problem with clinical trials. Highly select group, highly optimized, usually big teaching hospitals doing them, not necessarily real world cases. The patients come from different socioeconomic backgrounds to clinical trial. They tend to be better, more self-motivated patients that go into trials. I mean, these are generalizations, not always the case. But so when you're dealing with the real world, the results may not be as good as the treatment arm of a clinical trial that then becomes standard of care. So I think the future is about combining the intuition of clinicians with the evidence base of AI.
And to build on your ideas about prediction, so I think one of the biggest problems perhaps in cancer care has been kind of a static view of a patient's cancer, as in patient cancer is diagnosed and then one treatment is given, it's then monitored, but the doctors don't really have an idea of how that tumor is going to evolve. So they don't know if it's going to acquire a new gene that means they have to change treatment strategies. So do you think that AI is going to allow for a much more dynamic view of a patient's cancer, which I think is kind of what you're saying about predictive modeling? And how can that change a patient's outcome?
I think what we tend to do in oncology is have a set of numbers that become the holy grail. So we see a patient, we then start on treatment. We give chemotherapy every 3 weeks, for example. But how many cycles do we give? We give 3, maybe 4, maybe 6, maybe 8, that sort of thing. And these numbers have come out of nowhere. And it's just because clinical trials were set up with that number of cycles. They may not be the best for that patient. So the patient is on the right treatment, but how much do they actually need? The disease we've seen the biggest personalization pre-AI is germ cell tumors, testicular cancer in young men. So chemotherapy came in when I was first started in oncology. It was successful. Mortality was nearly 100% before platinum-based chemotherapy in 1974. It came to the UK from America. And afterwards, it became 98% cure. So a total reversal of cure versus non-cure.
Yeah, wow.
And now we've minimized the treatment because it's toxic. In young people, especially lung gets, the fertility goes, that's easy to sort by storing sperm, but the lung damage is not, liver damage, kidney damage, and so on. So what we can do is tailor the treatment. Some patients may need 1 cycle of treatment, for example. The same must apply to the common solid tumours such as breast, colon, lung, and so on. But we've not tried to adapt it because, again, there are too many variables to know how to do it. You'd have to set up long-term, complex, and rather dull trials that the pharma industry don't want to fund because they want you to give as much chemotherapy as they can produce.
Sure.
And so holding back on chemotherapy will be something that AI will probably be able to do to identify which patients don't need 6 cycles, that could just have 2 cycles, for example. The same with radiotherapy. Some patients probably could do with less number of treatments of radiation than others. At the moment, everyone gets the same. So, for breast cancer, it's usually 10 or 15 treatments to the breast. Maybe some people just need 2. Or maybe even just 1.
Right.
And you could work it out. And that would be based on radiogenomics, the sensitivity to radiation, both of the cancer and, more importantly, the normal tissue around the cancer. And that will come again over the next 10 years, I'm sure.
Has AI been as revolutionary as the media deems it to be? Or is it more like it's the natural progression, given computation has come a long way, next generation sequencing? I think when I was studying, even there was talk about some sort of way of measuring the temporality of next generation sequencing, basically combining static and dynamic modeling of a tumor. So do you think that it's been overhyped in the cancer community?
It has been totally overhyped. Every time I see a lecture on AI and cancer, I rush along or I download it and I come away profoundly disappointed because it's told me nothing I didn't know. And it's very difficult to find a lecture on AI that tells you something new on the whole. Even studies don't really tell you much new. I think you could say, well, that's what happens at the beginning of everything, but this is very much hyped up. And we're using AI without knowing it all the time. I mean, that's the other thing. I mean, we're looking at all sorts of things, using a computer predicting things. Even when you look things up on Google now, there's AI helping you out with it all. And I think how it goes forward, we want to see benefit, not just the AI program can pass the board exams for the postgraduate studies in oncology. We want to see how it can benefit a patient. And I think that will be the day it happens. And I don't think it's going to be long before it happens. The other thing is routine, very boring tasks that we have. Now, it's not so much in the treatment, but in the diagnostic. So reading mammograms is deadly dull. I mean, I'm not a diagnostic radiologist, but you can imagine you've got 500 women's mammograms sitting there. There's no symptoms. They've just come for screening. You've got to look at them. And the biggest error radiologists make is they get tired and they miss things. That's the human nature. You get tired, you miss things. Or you just get distracted. So you have to concentrate. And that must be digital information. It must be ripe for AI, and it is. Some people are now, I think 80% of mammograms in the UK are read by automatically, and the 20% doesn't mean 20% are abnormal, but 20% have something on them that the AI program is erring on, or it says, I'm not sure. And that goes to the eye of the experienced radiologists. And that's the way forward. And then I think the other thing is the training tool AI can be very helpful because, of course, if you don't actually intervene, there's no one's going to risk anything by doing something you shouldn't be doing. You can let AI predict what's going to happen for you. And so as a training tool, it could be very useful. But I think going back to your question, yeah, if there was an AI lecture tonight at 6 o'clock, I'd be there on cancer. I'd be there in London listening to it. And I know I'd go home wishing I'd just gone home. And I think that's the future. We're going to have to live with it.
Yeah. Do you think that AI poses a greater risk to patients or to doctors? Because I think patients might be distrustful of AI. Doctors might be distrustful of AI. Doctors might be over-trusting of AI. So who do you think is at greater risk here?
Patients ultimately, because doctors are only doing a job, the patient stands to get the wrong treatment. I don't think they will. I think if one goes hand in hand, the doctor and the AI, you get to a good solution. Can you have robo-docs? Can you actually get rid of doctors and decision-making doctors? So if you take frontline diagnostics, someone with a chest pain or something, can they just use their phone to have a robot talk to them nicely, just like a GPS in a car, talk to them nicely about what to do? And it's possible, and we already use NHS 111 here, which, although it's operators, the operators have done a weak induction. That's all the medical expertise they have, and they're following a computer algorithm. It's not much further to put, instead of having a live operator, just having a voice synthesized thing, like, when you call public utility services, they just have synthetic voices. It all sounds very pleasant, and that's going to get better and better. So that's one thing. The second thing is how, can it make decisions for you? Can you feed everything in, all the data we're talking about, in 50 years' time, and then the RoboDoc tells you this is the optimal plan, this is how we're going to do it. Any questions, you ask your question, the robot responds to you. Can you even synthesize, do a hologram with a real nice grey-haired senior physician sitting there? Is this what people want? Different people want different things. But I think NHS 111 has worked very well for minor ailments. It's diffuses a lot of minor ailments by going through an algorithm. And also picking up, it's very safe. So I was chair of the North East London 111 service for 3 years. So I did it for an afternoon, and it was very interesting. I was supervised. I wasn't allowed to override it. And it was very safe. And now and again, it would automatically call an ambulance if the program thought the question being asked deserved an ambulance, so it would come out. So I think there are ways we can use this, and we're already using it. What we're not doing is calling it AI, and that's the next step to put everything into the AI box. And who will lose out with AI? Will you need less doctors? Probably not, because we're all going to age, we're all going to have multiple problems. I don't think we'll need less doctors. The other problem for society, and where the biggest lack is in care, is direct care. It's difficult to imagine robots that can look after people in care homes, for example. And that's going to be the biggest problem. Although, having said that, maybe if I was sitting here in another 50 years, when I began in oncology 50 years ago, we could envisage little robots going around the care home like dogs. Hello, how are you today? And so you want to lift here? You want to be put into the chair? This sort of thing. But that's the biggest challenge for society. I think that we're going to have to face somehow. And it's interesting how the current government kicked the can along the road with the care strategy till 2028. And all countries have done the same. No one knows what to do. Japan's been through it because they have very, very low birth rate and a lot of very old people that are very frail. And they've created a whole structure, a big infrastructure around care homes for the elderly. But other countries like us, we're just head in the sand about it. And maybe AI can help. It can certainly help part of the way, but can it do it all? Who knows? A robotic care home awaits me.
the thing that you just talked about kind of ties into agentic AI a little bit, which is it garnered quite a lot of interest in 2024. Maybe it's lost a little bit of steam now, and it's been replaced by more exciting concepts like superintelligence or artificial general intelligence. Basically, an AI handling an entire process by itself. For example, a patient's treatment regime, and that can be even implemented over a long period of time. Do you think that there will be a place for AI, perhaps in the immediate future or in the distant future, like you said, where doctors aren't even collaborating with AI, but AI is just managing the entire patient journey, and perhaps a doctor still has to AOK it, but realistically, if you have this AI system saying, this is the reason why I think we should do this, yada yada yada, how likely is a doctor going to rigorously check the underpinnings of that decision? Do you see a place for that, and do you think it's too risky?
Doctors probably won't get the choice on all this when it happens. If it happens, it happens. Can you get a sophisticated enough system that the customer is happy with, the patient has to be happy with it, and the family has to be happy with it, to allow them to, the doctor's irrelevant to it all. You're just standing there and just sitting like like a train driver on the line in East London, where there are no train drivers. Now and again, someone gets on and pretends to drive the train, but on the whole, the train's computer controlled. Yeah. Can you have the same thing? The doctor may sit there, not touch anything, just sit there for everyone to look, so they look happy. I don't know. I'd like to think not. I'd like to think there's something about medicine that there's a human element to it.
Yeah.
But I can see a lot of the first thing to go will be the drudgery. It already has gone. So, for example, when I gave chemotherapy 50 years ago, I'd write it all out by hand. I'd draw it out of the syringe myself. I'd do all this stuff. I'd collect it. It was 10 o'clock at night on my days off. I'd still be giving chemotherapy at Barts when I was a registrar, and my first job in Oncology. And now it's a computer program. It checks what you've done. It checks the weight, height of the patient. It checks the temperature, the blood pressure, and everything before you can give it. It checks the pathology is correct for the drugs you've given. It checks the doses very precisely. I mean, I've seen on 3 occasions in my 50-year career the drugs being written into the wrong box by hand on a prescription sheet. All hospitals have different format in the prescription sheet. And sometimes the junior doctor writes it on the box to be given every day instead of just one off every 21 days. And that can be lethal. Luckily, none of the patients died, but it's pretty close on one occasion. Someone developed dreadful septicemia, having been given 5 days of chemotherapy when they only should have had 1 shot. The computer can stop all that because it can spot that immediately. And so that's an advantage. Whether you can go further and take the doctor away completely from the computer, I'd like to think it won't happen in my lifetime, but it may happen in your lifetime.
We shall see.
We shall see.
Do you think that people like yourself, people at the top of the field, have a completely different attitude to the younger oncologists who are just starting out on their career when it comes to AI?
We do, because my generation were born and actually practicing before computers existed. I remember the Sinclair computer connected to the television. You wouldn't even remember. You weren't born when that happened, which it was pretty useless by modern standards. And then very excited because at Hammersmith, where I was a junior doctor, working on renal medicine, the lab installed an old-fashioned valve computer outside, and you go at night and with the appropriate code, you look up people's blood results. I thought, this is fantastic. This is the future. And it was the future. Because before that, the only way you get results is to phone someone up. And at 3 a.m, there's not many people around to phone up.
Yeah. Wow.
And you can actually physically go to the computer. It was like the Wizard of Oz. You ask the questions. Tell me the blood urea of this patient. The blood urea of this patient is 22. It always had a posh voice when it spoke to you.
Of course.
And and you think that's not so long ago. I mean, in the sort of generational terms, not so long ago. And of course, the pace of change is accelerating all the time, especially in the whole area of computer technology. So as it accelerates, who knows, maybe the blood results will come to my brain directly. But you wouldn't need the blood results. The blood results would go into the machine controlling the patient. Every patient would have a computer of their own that would be controlling what's happening to them.
Yeah.
So,
obviously purely hypothetical, but still interesting to talk about. Let's go back to cancer treatment itself, and I think we should talk about immunotherapy, because that was quite a breakthrough moment, I think, for oncology, was the discovery of immunotherapy. And for listeners, I think you're better placed to explain this, but immunotherapy hinges on the fact that cancer cells often mutate to avoid the immune system, and therefore there was a theory that if we deliver a drug that then reactivates and amplifies the innate immune response, our own body can then do the cancer killing rather than administering a drug that kills the cancer cells directly, which in theory sounds incredible. And it seems like that should be the way of curing a cancer completely. If you are protecting yourself, if you are actually identifying our own body's mechanisms and hijacking them to basically kill the cancer cell, then surely the cancer will go completely. But why isn't that the case? Immunotherapy does not have a 100% success rate.
So immunotherapy has been around 100 years, but current immunotherapy really began only 10 years ago in 2015, when a series of drugs came into being called checkpoint inhibitors. These drugs, such as ipilimumab and nivolumab, pembrolizumab, they basically stimulate the body's own T lymphocytes to react to things, to react to the cancer cells, but also to react to other body cells. So one of the side effects of immunotherapy is what's called autoimmune problems, and the thyroid gland, the adrenal gland gets affected. Well, that's not a problem, because you can treat that. You can give steroids or thyroxine and so on. What's been surprising over the last 10 years is how ubiquitous they have in the value to different types of cancer across the body. So immunotherapy began with melanoma and kidney cancer, which were known to have rather strong antigens on them, which were different from the rest of the body. And by activating the T cell system, by taking the brakes off the T cell system, which is what checkpoint inhibitors do, you got death of the cancer cells, and although there were some side effects, several cures, and they were durable cures for the first time. And that led to people trying the same drugs in other common cancer, head and neck cancers, kidney cancers, diseases of the gallbladder, tumors of the lung, and so on. And the biggest problem with these drugs is predicting who's going to respond. The drugs are expensive, £100,000 a year sort of level. Wow. And for a shot every 3 weeks, that's all you get, and that's all you need. So the problem is they're expensive. The other problem is we can't predict who's going to respond very effectively. So the response rate depends on the type of cancer. If you take head and neck squamous cell cancer, it's about 40% of patients get very good responses. If you could predict who is going to get a good response, and more importantly, who's not going to benefit at all, you would not only save money, but you save time and everything and hope for the patient. So that's the big challenge. And we try and do it by looking at various factors such as the PD1 and PDL1 gene expression. These are ligands that block the T cells coming in there, but it's not very effective. The quantification of these proteins is very poor. So the future is going to be about identifying better biomarkers for response to immunotherapy. And again, that's where AI comes in, because it can see the bigger picture. It can identify patterns that make a tumor, as you said, with a high mutational burden, for example. These are ones that are likely to respond. Those that have high PDL1 are likely to respond. So we look for those factors together with all the secondary effects that you can measure to move the whole thing forward. And once you have that, it becomes it's cheaper. The overall costs of using immunotherapy become cheaper and more effective because you only target those patients that would actually benefit, not those that wouldn't benefit. So I think immunotherapy is with us forever. We can make cheaper drugs. We can make oral drugs. That will be the next thing. That's definitely coming because the drugs we have to be injected. It's not the end of the world. Patients can even inject them if they're subcutaneous. They can't inject them if it's intravenous. So everything's possible. And again, AI will come and solve the multiple factors at interplay here.
And if you Google immunotherapy, there are quite a few articles that name that as the future of cancer therapy, as in immunotherapy is the future. Do you agree?
It's a combination. Probably immunotherapy can mop up a small volume of cancer cells. The immune system is not able to deal with a large solid tumor. So you probably still need surgery, maybe radiotherapy, maybe even chemotherapy to deal with that. And then the immunotherapy comes in as an adjuvant, as we call it. You throw it in, adjuvant, a javelin, to mop up any remaining cells around the body and to prevent any cells that have got stuck, say in the bone marrow or in the lung, from actually coming alive. And it may be given for the rest of a patient's life in small doses. That's how I can envisage it, to keep everything calm. Of course, the real question, how does cancer arise in the first place if the immune system is effective? And once it grows to a certain size, the immune system is clearly not effective, and therefore can you reset the whole thing? That would be the way forward. And then with AI, can you reset it before the tumor actually arises? And can you predict this patient you're going to get colon cancer, and therefore I'm going to give you immune tinkering to prevent your cancer cells. So those cells are recognized by your immune system before they actually develop into anything that we could detect clinically.
Interestingly, I think, so autoimmune diseases are on the rise as well, and particularly after COVID, a lot of people's immune systems were pretty shot by that and developed more things like type 1 diabetes, for example. With those autoimmune diseases, are you more likely to get cancer? And if so, then how can we ensure that those people are protected against cancer just as much as the normal person is?
I think we don't really know what's going to happen with the RNA vaccines. It's like a living experiment because, of course, it was never tested in the way that you test a new drug in large cohorts of people before it went viral, so to speak. Yeah. And there's no doubt it's going to be a challenge. People are making outrageous claims that COVID lead to turbocharged cancers and so on. I think it's rare. We've always had turbocharged cancers. I don't think it's the vaccine that's done that. It will be interesting to see if there is a change. It'll take time, 10 years, that sort of thing, before you begin to see it.
Interesting.
And if it does change, then what are we going to do about it? It's not going to be easy.
You don't think that the vaccines are going to be revolutionary? Because when did cancer vaccines first come about? I think it's quite recent that it's been approved. Could you explain what the principle is?
We're talking about cancer vaccines to prevent cancer.
Yes, yeah. Sort of naturally leading on from autoimmunity.
Yeah, the concept's been around about 50 years, but the practicality and the approval of the MUC1 vaccine for colon cancer and for breast cancer, the trouble is you have to identify which patients to give it to, and that's the problem. We don't know which people to give it to. There's no point giving. It's not like, COVID virus vaccine or measles virus vaccine. It's impossible you give it to everybody. But we don't have a poly vaccine to give to everybody for cancer. So, and also it'd be very difficult to sort out because cancer still is relatively rare. So in a certain type of cancer is relatively rare. You'd have to vaccinate a lot of people for a long period of time before you see the difference in a trial. So that's one of the problems with all this, that I think can we identify who's likely to get things? It's like the film, I've forgotten the title of the film, where you predict where bad guys are going, the precogs, the bad guys. And then you stop the crime by going to the spot where they're about to commit the crime and arrest them before they do the crime.
Right.
And so that's exactly the concept of the vaccine for cancer. You stop it before it happens. And is that feasible? Maybe. And will AI help with that? Possibly, because it can look at the multiple variables again in the patient prior to the actual arising of the cancer cell.
Have you seen any innovations or any particular research papers that spotlight a technology or other measurable implementation, and you've thought, this is really exciting? Have you seen anything that you think is really promising for the future of cancer care?
I think it's the prediction. It's the prediction of who's going to get cancer, and the prediction of what cancer is going to, how it's going to behave itself. Because, having cancer is not a big deal if you're going to live for another 20 years with it for most people that get cancer, especially something like prostate cancer. The average age is 72, so you're going to live to be 90, so it's fine. I think the difficulty in the whole thing is looking for patterns that we can't see. If you looked at all the data in the literature, all the data in the path labs around the world and did correlations, you could, with a huge computer, you could probably see correlations that the eye hasn't seen, that we just haven't observed. And I think that's where something like the NHS could be fantastic, because it has all the samples, it has all the data. It doesn't yet have a supercomputer, and maybe that is the way forward, that you actually look for patterns, not just for cancer, but the whole of healthcare. And you look for patterns to predict who's going to develop what, and therefore by doing that you have tailored screening programs, tailored treatment programs, and so on. And I think that probably is the way things will go forward.
And you are an advocate for patients taking a bit more responsibility for their own health, because I think you've acknowledged that the NHS is crumbling, its capacity is so diminished at the moment, that there's no promise that you're going to get the treatment that you deserve. So what does that in practice look like?
I wrote a book 2 years ago about making the system work for you for cancer. And the idea is that you can get the best care in the world out of this system here, as you can in most of European systems. But often you get sidetracked by various problems, logistic problems. I mean, you're not the only fish in the sea, basically. And so how selfish do you have to be to make sure you have to push yourself to the front of the queue. And if you look at cancer care in the NHS, there's nothing wrong with it when you get to the front of the queue. The chances of you getting to the front of the queue are variable. It depends where you live, how you behave, how your educational understanding of what's going on. It's not a consumer-friendly system. Budget airlines, you may not like checking in baggage and all the rest of it, but it's a consumer-friendly system. The booking process is made as easy as possible, whereas the NHS, it's not at all easy. And the biggest difference in outcomes are caused by delays in the diagnosis of cancer. So if you compare our cancer survival to here in France, we're spending about the same on healthcare, or even Eastern Europe, Poland, for example, and you look at the data, it's clear that British patients are getting much poorer quality of care. And it's not the actual technical quality of treatment that's different, because once they get to the front, they get the same. It's simply the time it takes to get to the front. And the best example of that is the target in the NHS from diagnosis to treatment is 62 days. It's 2 months. In Poland, it's 7 days for the same target. And that's Poland, which is not necessarily the most advanced country. It's sort of middle in the European range of outcomes. And during that 62 days, a third of trusts are not meeting that demand. They're not meeting the target since COVID. Patients have got cancer. It's confined to a single organ to start with, stage 1. 90% chance of cure for all the 4 big cancers, breast, lung, colon, and prostate. And then You wait 2 months, some of those cells are spread outside to lymph nodes, they spread to distant nodes, to the liver, to lung, and so on. So it's downstage, it's staged up, stage migration we call it. It goes to a poorer stage for treatment. And for most solid tumours, the treatment for stage 4 cancer, the results are less than 10% cure. Whereas for stage 1 cancer, 90% cure. So delay kills. And so, but unfortunately, in a restricted system like the NHS, delay is the most powerful rationing device we have. So if you're a manager of a hospital and you've got to ration things, there are 5 Ds for rationing. So delay is number 1 by far, because you delay things, people will go privately, they'll die, or they'll get bored, and so they'll go away. And at the moment, as you know, 7.4 million people are waiting for something in the NHS. Okay, some of them may be waiting for 2 things, so there may be less than that, but the 7.4 are waiting for something. And there's not much sign of it really going down. And it's difficult to see how you can get it down in today's system. So making the system work for you is about trying to get yourself to the front of the queue nicely.
It's quite an unsettling thought that our health system leans into an ideology of social Darwinism, where if you're nicer, or if you're a bit more forthcoming with your doctors, they're going to favour your treatment, either consciously or subconsciously, over another patient that is perhaps more standoffish or quieter. With that in mind, do you think that AI can be a bit more of an equalizer and help standardize how patients receive their care, like in what priorities they receive their care?
I think what it can do is look for the red flags that we don't look for, we can't see, that suggest this patient needs to be pushed to the front of the queue for medical reasons, not because they're nicer or better spoken or something like that. And that's definitely feasible. It can look for things that we wouldn't normally see in there. And we've tried. I mean, GPs are given red flags for cancer and they're told to do this, but they're not sorting the whole thing out. It was interesting. One of the theses in the book was, you have to be polite and nice. You can't be nasty. If you get aggressive, you will be put to the back of the queue, and no one's going to try and help you. And it's the same everywhere. It's just common sense that that's the case. So the Daily Mail reported the book, and they wrote a bit about it and said, "Doctor says give the receptionist flowers."
I read that, yeah.
And I thought, well, it's true. I mean, people are human, and receptionists get a lot of stick in the NHS because it is a ration system. A lot of people phoning them up, swearing at them, and using nasty words. And and it's not their fault that the system's like that. And why should they take verbal abuse from people? And they're not going to react pleasantly. So it's not necessarily the person you think that's important that's making the decisions. It's often someone far down the food chain of the hierarchy in the hospital that's actually making the decision to give you an urgent appointment next week instead of making you wait 6 weeks and so on.
Yeah,
they're the important people in the control.
So regarding the NHS 10-year plan, do you think that we're trying to stick a plaster over quite a substantial hole that can't really be filled? Do you think that we need to scrap the NHS altogether, or do you think that AI and novel technologies are the saving grace that we need?
I don't think AI will save the NHS. I think it will help patients, definitely, but it won't save the NHS. The NHS needs to do something different. The 10-year plan, very well, beautifully written by Oxbridge civil servants, I can see, and makes sense, the whole thing, but expensive and no roadmap of how to do it. And where you're going to get the workforce from. It's easy to say these things, but where are the people? And
Absolutely.
How are you going to pay the people to do what you want them to do? And where are you going to house them? This sort of thing. It's not straightforward. Hospitals are crumbling. General practice is sort of outside the NHS, although it's partly in the NHS, but it's like corner shops, the different size of health centres around the country. So I think what AI can do is really try and identify, if you've got a ration system, who to sort of take out to rescue from the system and put to the front. A lot of people that get CT scans or MRI scans, probably 80% new scans are not necessary. If we were better at diagnosing things, we could avoid them. That would mean the people that do need them, the ones that are likely to have cancer, would get them next week, as in Poland, which is fantastic. That's what you'd want. Can I help with that? Almost certainly it can, but can it do it quickly? I don't think quite as quickly as we need to do something. So I think, everybody says, well, let's get a European model of care, because they're spending about the same amount of money on healthcare as we are here.
Yeah.
And yet we're not getting the same service you get in France.
Yeah.
And of course there, it's a social insurance model rather than a tax-based total model.
Yeah. Just to end on a bit of a lighter tone, do you have a particular patient case that really touched you, or a particular story that you've always carried with you over your years of oncology?
Sure. A delightful lady, I won't mention her name, who I first saw 30 years ago and died last year. And she lived in London, a very posh lady. She'd come very posh. She was an NHS patient at Hammersmith. And she had metastatic breast cancer 25 years ago. And she lived 25 years. I thought it was just amazing. I used to go and visit her in Tenby for follow-up. She retired with her husband to a little house in the town wall of Tenby. I used to go and have dinner. She'd always get lobster from the harbour and give me and my wife lobster. And we went to a walk on the southwest coast path, which goes by Tenby, and not the Welsh, the Pembrokeshire coast path. And it was fantastic. And it just to see, and she used to get old. She died at the age of 85. And, fantastic.
That's fantastic.
And why did she survive 25 years? I mean, we did treat her, chemotherapy, hormone treatment and so on, but there's no explanation of how she could live so long. And I've had several other patients like that. There's an inexplicable longevity in people, and there's absolutely nothing. They were happy people, but they were probably happy people anyway. But it's a difficult one. Maybe happiness is the cure for cancer.
Wow.
There you go.
Well, we've heard it here first, folks. Thank you very much for coming here today and for talking to me. It's been fantastic.